Thank you very much for the introduction. I give this presentation on behalf of my colleague Bakker, who unfortunately couldn't come because of clinical duties. As said, this presentation will be on a meta-analysis she performed to evaluate what data is present in the literature on a correlation between temperature or thermal dose during radiotherapy and hyperthermia to our clinical outcome. So to introduce, this is confined to patients with local regional recurrent breast cancer treated with hyperthermia radiotherapy. And we know that radiotherapy alone would give a complete response rate of about 40% and 20% more if you combine with hyperthermia, as also found by this meta-analysis by Niloy Datta. So that is true, but at the same time we also know that there was a strong variation in the complete response rate. And the question is why? And we know that the possible causes can be multiple, so because there are patient-related, tumor-related causes, and previous treatment will also play a major role. Radiotherapy dose, of course, but in this case we will focus on the effect of the hyperthermia treatments. So that could be the time interval, but particularly the number of treatments, the duration, the thermal dose, and the temperature level. So we're going to check the relationship of these parameters during hyperthermia with response, local control, overall survival, and also, in addition to that, thermal toxicity. To this end, a meta-analysis was performed, checking a number of databases, as you can see here, screening a lot of titles, excluding many records based on title and or abstract. And after verifying eligibility, also in full text, we included 25 studies in this meta-analysis. Reasons for inclusion also included that sometimes data were reported in multiple papers, or that there was no analysis performed, or part of the information was not reported. So that means we ended eventually with 22 articles, which involved more than 2,000 patients, the majority of which were macroscopic disease, and almost all of them recurrent disease, and 23% microscopic disease. Previous treatment, like I said, usually pre-treated, heavily pre-treated. So in all cases, almost all cases, radiotherapy, but in many cases also surgery, chemotherapy, and hormonal therapy. So the present treatment was also very variable. So radiotherapy, the median was 36 gray, and hyperthermia, as you can see, almost 1 hour, usually 5 treatments and 1 or 2 treatments per week. And if we look at the way these patients were treated, actually the far majority were treated with microwave systems, but also some other heating devices were used. Main issue when reviewing all these papers is that the temperature measurements were definitely poorly reported, and there was also a wide variety of thermal parameters reported. And we tested these for the relationship with the aforementioned parameters. And what we found is that the superficial sensors, so the sensors mounted on the skin, showed no relationship with outcome, with clinical outcome, but only with thermal toxicity. And up to a certain degree we can all appreciate that that was the case. Whereas if we look at the clinical response rates, as you can see in the table below, it was only the invasive thermometry, or sometimes invasive combined with superficial thermometry, which could be linked to the response rates, local control, and overall survival. So these are the response rates for a number of studies, and what you can see, it's fairly small, but actually in all of these cases the cohort was divided in two about equally sized cohorts with a cutoff point for a certain dose parameter or a temperature parameter. And in all of these cases there was a clear relationship between thermal dose or temperature and clinical outcome, the complete response in this case. Also when you look at the complete response odds ratio, you can see that all of them actually, most of them are suggesting an improvement, in some case statistically significant, sometimes not. And the same applies to local control and overall survival, in that case only 2 studies. If you look at thermal toxicity, then the relationship is much clearer, and you can also understand that, like I said, the thermal toxicity is very clearly correlated with the measurements also on the skin. So there were more data present to corroborate this relationship. And in the case of thermal toxicity, we could also map the likelihood of thermal toxicity correlated with the temperature measurements performed at our institute in a recent study. That's the graph shown in the back. And then when we match that with the data reported from other studies, we see there is some correlation, although in those studies the damage appears to occur already at lower temperatures, but that's probably because there less thermometry was used, which means that the thermometry could not indicate the real temperature maximum in those cases. So concluding, higher temperature, tumor temperature and thermal dose do improve clinical outcome, but of course also a higher maximum temperature and thermal dose are also linked with thermal toxicity, and the superficial temperature and thermal dose are not related to clinical outcome. And that's in these cases mainly because when you're using a microwave system, which was the case in 90% of the cases, the water bolus temperature has a severe impact also on the measurement at that location. It's also very intriguing to see that when you look at the meta-analysis by data, you can see that if you compare radiotherapy alone versus radiotherapy plus hyperthermia, you see about 20% increase in response. And if you compare that with the difference in response for, let's say, a high-dose hyperthermia versus a low-dose hyperthermia, you actually see a sort of similar difference, which suggests that it's really, really, really very crucial to give good hyperthermia. So studies reporting radiotherapy and hyperthermia in recurrent breast cancer patients. Overall, the quality of hyperthermia is poorly reported. Several studies do actually attribute the low number of sensors to their inability to find a dose-effect relationship. And the included papers were actually, the main aim of those papers was not to investigate the existence of this dose-effect relationship. So we cannot really take that for negative. So summarizing, again, higher tumor temperatures are really crucial. But also you have to be careful not to cause a lot of toxicity, and superficial temperature and thermal dose are not related to clinical outcome. So we also feel that more research is needed to really find that dose-effect relationship. Thank you for your attention.
Thank you, Hans, for that very clear presentation. Other questions?
Thank you, Hans, for the excellent presentation. It was really very nice to see that there was a thermal dose relationship on the outcome. I was just wondering, because since you are trying to look at the multiple parameters here and try to see which is the parameter, did you attempt a meta-regression?
In this case, we did not, and that's also because the way these thermal dose parameters were reported was, well, a bit varied, so that made it more difficult to perform a meta-analysis in this case. But I agree that that would be very powerful, so we are planning to perform this kind of analysis on our own patients, and particularly those treated more recently when we have more thermometry, and then we will definitely do a multivariate analysis as well.
Was there any studies reporting quality of life of the patient? Because there is direct effect between toxicity and efficacy.
This is, as far as I know, because first of all you need to look at those studies which reported extensively on the toxicity analysis, and those were quite limited. Those studies did not involve the quality of life as well. But let's put it this way, if you know about the let's say the grade 3 toxicity, you know it will have an impact on quality of life, generally.
More or less, but if it's rated with the complete response, patient can accept some temporary toxicities.
From my own experience, they actually do. Yeah.
Okay.
Yeah.
Thank you, Hans, for a very nice presentation. I wonder, can these data be used for QA guidelines, telling that the interstitial temperature measurements are required? Because at the moment they are strongly recommended. And what is necessary? What kind of work is necessary to require?
Yeah, I tend to agree with that, because we require good measurements for deep hyperthermia. So it is almost self-evident that in case your more superficial tumor reaches sufficiently deep that you actually cannot tell anything about the temperature at depth by just superficial measurements, that you should also include interstitial measurements. My feeling is that all those institutes reluctant to do this will find that if they start doing this, that this is actually quite feasible to do so.
Very short question.
No, it's more a remark, because one of the differences, so thank you for this very nice presentation. Let's start that first. But I think one of the issues not addressed here is the depth of the treatment of the superficial hyperthermia treatment, also on the radiation. I mean, I have had many years a discussion with Paul Stauffer on whether extension of breast cancer is up to 2 cm depth or 1 centimeter depth, or up to 4 cm, and in radiation we often take 4 cm.
Well, okay, I can of course say that for the papers reported here that it was impossible to determine the depth, but at least in our institute, and I assume also in your institute, we discuss every patient before starting treatment. We look on a CT scan how deep the tumor is reaching. This is verified from
This has serious consequences for where you put your thermometry.
Yeah,
This was the remark on if you write QA on this.
Yeah.
So you need also the clinicians.
Yeah, the
to have
clinicians
a
need
uniform definitions.
Yeah, the clinicians need to be aware that that tumor has dimensions, and we always require them to make a clear statement how deep the tumor reaches. They give the number, so they are also responsible for the decision that, in that case, thermometry, invasive thermometry, should be present during treatment.
Thank you.
Okay.
Now, Dr. Siles.